Hello and welcome everyone to a very special edition of the Lipid Insights podcast. I'm coming to you live from the MNLA Fall 2025 Clinical Lipid Update in Scottsdale, Arizona. I'm your host, Dr. Peter Jones, and I couldn't be more excited about being here to talk to some of the brightest and most passionate professionals in our field. So if you're tuning in from anywhere across the country, this podcast is your backstage pass to ideas, conversations, and energy that make the CLU experience unforgettable. So we've got a fantastic discussion scheduled ahead. So let's dive into the spirit of the MNLA Fall CLU. So today, I'm here with two people. First, I'm here with Dr. Amy Shah. She is a pediatric endocrinologist, clinical lipidologist, and a professor of pediatrics at Cincinnati Children's Hospital Medical Center. She's the division director of the pediatric endocrinology and director of the adolescent type 2 diabetes program. And she currently serves on the board of the Midwest Lipid Association chapter. Amy, why don't you tell us a little bit about what you do? That sounds pretty fancy. So what do you do every day, though?
Yeah, so thank you. Well, it's a pleasure to be here. And so what do I do every day? Take care of kids. That's probably the number one reason I go to work every day. In my other roles, though, I do some administrative work, and I have a big passion for research as well. So trying to improve outcomes in kids with lipid disorders as well as type 2 diabetes.
That's fantastic. Well, you know, the other person on the panel is a longtime friend of mine and a fellow Texan, Dr. Don Wilson. He's a pediatric endocrinologist and has devoted the past 20 years of his career to cardiovascular health and risk prevention in children and adolescents. He currently serves as the endowed chair of the Pediatric Cardiovascular Health and Risk Prevention Program at Cook Children's Medical Center in Fort Worth, Texas. And he's always had a lot to do with the MNLA. And he also serves as one of the associate editors for the Journal of Clinical Lipidology. Don, you're fantastic. And I just, again, tell the audience, what do you do every day?
Thank you, Peter. It's a privilege to be here, especially with Amy Shah. What I do every day is what I've loved to do now for about 45 years, and that is see children and interact with families. These are near and dear to my heart, and I think we all would agree that the children are our future. But what we're trying to do, Amy, myself, and others across the country and across the globe, is actually keep our kids healthy as they grow up. We want these kids to aspire to be the best whatever they can be, but we know that they have to stay healthy, and some of these kids have health risk. And so we're all about trying to identify those and then, in a very caring way, try to get these families to adopt healthy lifestyles that will encourage their kids to be healthy as they grow up.
Oh, that's awesome. And you know what I like is that the MNLA has really made a big effort to start including pediatrics, and in a variety of ways, not just lipid treatment, but also obesity, because I think, you know, the overall purpose of the MNLA is to really earlier is better over the long haul. Whatever you identify and whatever you can do earlier creates greater outcomes over a person's life. So it's great to have a lot of experts here in this meeting helping us get to that point. So, you know, one of the things, Amy, I wanted to start with was about in your discussion is about lipid screening in the pediatric population. So should we screen, and why should we screen?
Yeah, that's a really good question. So, should we screen? Absolutely, yes. So, just as you were alluding to, you know, screening offers the best opportunity for early detection. And I think several organizations and probably, you know, just have recommended that we should screen early. We now have universal lipid screening between 9 to 11 years of age in pediatric patients, and then again after the age of 17. In pediatric patients that are at higher risk, it actually is recommended to screen after the age of 2.
Okay. What are those higher risks?
The higher risks are usually family history
Okay.
of high cholesterol or being on or having a parent on a medication for cholesterol lowering. If there's an early history of cardiovascular disease in the family, so early stroke or early MI, and then really if the family history is unknown, a lot of times, we have kids that come to our clinics that are screened, and we ask about family history and. Either the parents haven't been screened or they don't know their levels. And so sometimes it's hard to get a little bit of a stronger family history. But I think moving forward, as more kids are getting screened, they'll know about their risk for their children.
Yeah. So the American Association of Pediatrics, these are their guidelines about screening, correct?
Right, exactly. And those have been pretty much adopted by every organization, including the National Lipid
And the NLA is in on that too.
Yes.
Is LPA included in that screening also in the pediatric population?
Yeah, so from the NLA, actually, there are recommendations to screen Lp(a), but mostly in kids with higher risk. So again, the same risk factors that we were talking about, if those are present, then yes, you want to go ahead and it's recommended to at least evaluate it. Lp(a) levels are pretty stable after about the age of 5 years old in pediatric patients. So at about that time, you can get that, and that's pretty much what your level is going to be.
Do you find that pediatricians are following through with these recommendations on lipid screening? Does the EHR help them say, have you done this? They're the right age. Does it do that?
Yeah, Dawn might be able to comment on this a little bit more, but I think the uptick of it, has picked up. It's taken about 10 years. We're about 10 years out from I think the guidelines first being recommended, but we see a lot of our referrals are for, the presence of dyslipidemia in that age group because of universal lipid screening.
You agree with that?
Yeah, just a couple of thoughts. I think our audience knows this, but screening is just starting the conversation. We're not in the business of trying to tell parents or pediatricians that these kids need medications necessarily, but a lot of reasons that we're doing this is because these children have genetic disorders, which means that they're born with a high cholesterol, and in the absence of treatment, they have significant risk for cardiovascular disease. So we're just starting a conversation. The other beauty of screening, I'll tell you, is that we identify a lot of young people who are athletic, they're involved in dance and all type of activities. They have normal body weights, yet they have this genetic predisposition for high cholesterol that puts them at risk. So in the absence of universally screening these kids, you wouldn't pick them up until late and when they've had an event or something like that. So that's kind of what the effort's all about. Just a couple of key points for those listening. A, you don't have to fast these children.
Mm-hmm.
B, you don't have to fast these children. C, you don't have to fast these children. And the reason for that is that there's ample data now that if you look at total cholesterol, LDL cholesterol, HDL cholesterol, it doesn't change significantly. In fact, the triglycerides only go up about 26 milligrams per deciliter after a meal. What we're confused by is that 10% of children, world population, but children in particular in this conversation, that have triglycerides over 150. So, your 2 o'clock in the afternoon child's not going to be fasting, but that's the opportune time to do the screening, because otherwise you have to ask them to be late for school one day and the mother or dad be late for work. And so that's really been a barrier. But we've all learned it in medical school. We need to unlearn that.
Right.
So the idea would be to screen every kid at that time, at that moment, if they can. And then for that 10% that might have triglycerides, say over 150, then you have an opportunity to call the parent and say, hey, it's a little high. We need to investigate this a little bit. It makes a lot more sense than doing it the other way around.
Yeah, so you can say come back at a fasting level at a time that's convenient for you, or kids out of school or something. And
right, because if that triglyceride is significantly high, however you define that, then those kids are going to need a workup to define why that is. Right.
That sounds reasonable. I mean, do you find that the screening is, when it's universally recommended for lipids, but do they also check for presence of obesity? I mean, is that the routine thing? Is the usual guidelines of what is obese in adults also apply in kids?
Yeah, so it's a little bit different, and that's so in adults, we use cutoffs per se. In pediatric patients, we have growth charts, and so it kind of follows kids all the way from 2 all the way up to age 20, and you can actually plot the weight, the height, and then calculate the BMI. So there's percentiles
Okay.
that are essentially used for BMI to define what is overweight and what is a child with
Child
obesity.
obesity.
Yeah.
Okay. And you tend to deal with type 2 diabetes in adolescents. What do you find the most common predisposition is to type 2 diabetes in adolescents?
Yeah, so that's it. We thought we knew, and it's more complicated than we thought it was. And I think the truth is we know that overweight and obesity can be a risk factor, but it doesn't tell the whole story.
Okay.
And actually, we have a lot of kind of investigations around that because we want to know is it, what is the contribution of the diet, physical activity, genetics, the environment, and all kinds of other things. So I think it's much more complicated, but we definitely know that healthy lifestyle and focusing on that can help prevent both obesity and type 2 diabetes.
Yeah, and I assume that in a clinic that sort of is on board with universal screening for lipid disorders as well as the potential for obesity, you have to have a multidisciplinary team, don't you? Available to do that?
Yeah, absolutely. It takes a lot of time, conversation, and discussion. But I want to give a lot of credit to the primary care physicians because the burden to screen kids for any
Hmm.
either metabolic syndrome, obesity, or in this case lipids, really kind of falls to them. So they've done a tremendous job. You mentioned the EMR, other ways of trying to improve compliance rates and so forth. What we ask for them is not to disrupt their very busy practices because they have so many things they have to get accomplished in their short visit times. But we ask to partner with them so that we actually have the resources. Many of these clinics don't have dietitians, for example, which is incredibly important for all these disorders. But if we can just simply get the screening done and get those kids into the appropriate environment, we can use those resources that are available to us to help start the education process, start about talking a little bit about behavior modification if it's going to be helpful, and then eventually talk about the manifestations of genetic testing and lipid-lowering medications if they're going to be helpful.
Yeah, same thing with diabetes clinic. I bet you do have a lot of
Yes.
multidisciplinary help, don't you?
We do, and it really takes a village to do all of the things. But yes, we have nutritionists that partner with us. We also have exercise physiologists. We have gastroenterologists. We have psychologists. It's all of these things are complicated conditions, and it can't just be done by one single provider. So we try to, have resources for families so that they have the tools that they need that we can support them.
Yeah, I think that's amazing. I do want to take a moment, Don, to and Amy as well, to highlight a JCL Journal of Clinical Lipidology article that you published this year entitled "Metabolic Syndrome in Youth: A Fresh Look at an Old Problem." Okay, so what is the metabolic syndrome in adolescence? Is it the same as it is in adults, or what?
I wish I knew. Uh, well, the concept of metabolic syndrome has been around for quite some time, and it basically just sort of points out that there are multiple risk factors that are present even in young children that if you don't address those risk factors, then they're going to continue into adulthood, and there's pretty good data that shows that. So of all this constellation of things, in general, the answer to your question, Peter, is that, yeah, they're pretty much the same. So dyslipidemia, some evidence of high blood sugars at fasting or glucose tolerance tests or whatever you're going to do, A1Cs perhaps. Blood pressure issues, some disorders of lipids, and they're different in those children who have pure metabolic syndrome or insulin resistance versus the kids that we're talking about with genetic disorders.
Okay.
So you have to kind of be able to sort the deck a little bit there. And then in girls, they start having menstrual issues, particularly during, their ages 14, 15, 16. They'll have very erratic or secondary amenorrhea. So there are a lot of things, and then Amy alluded to, maybe she can elaborate on this, but I think the thing that's under-recognized perhaps is the profound thing that we see in terms of just depression and some mental health issues. Amy, you want to talk a little bit about that?
Yeah, I think, well, when we originally, wanted to put this special issue together, we thought that there's a lot of things going on, right? Just as you alluded to, the metabolic syndrome not only is a constellation of kind of manifestations or disorders that can be present in individuals, but it takes a lot to kind of get together and think about how do we treat this, And I think part of getting this special issue together was to focus, how can we use nutrition changes? How can we use exercise? How do we get kids moving, in this day and age when it's we've got TV and we've got YouTube and we have, Instagram and social media. How do we get kids moving? And that was really the point of, putting this together. But I think in turn with that, though, is that, there are mental health things that these our patients are experiencing, ranging from bullying, being made fun of, depression, and these are things, and mental health is just as important as physical health, and as pediatricians and pediatric providers, we want to take care of the whole person, and sometimes those are the things that we need to address first and foremost, and then we can get to the other things after.
Adolescents are in a very complicated part of their development and self-esteem and other things, and you add some of these issues on top of it, and it only makes things worse, along with the bullying, as you mentioned. You mentioned in the metabolic syndrome, probably different for adolescents than it is maybe in older adults, but for women, you're mentioning irregular menstrual periods. Is that polycystic ovarian syndrome? Is that what it is?
For the most part, yes.
Okay.
So we know that based on current information that metabolic syndrome really is insulin resistance for the most part, and that is kind of one of the keys to PCOS.
Okay. Is there any ethnicity propensities for this metabolic syndrome?
It tends to be more common in blacks and Hispanics.
Okay.
More so than whites, but we see it in a lot of different races, and so one more so than the other, but not necessarily exclusive. I think most of our audience really knows about acanthosis.
Nigricans?
Yeah, and so I bring it up because at least in the state of Texas, perhaps other states, we actually have state legislation that has the school nurses screen for that, and so that increases a lot of referrals, and so we start seeing the kids early on, and that's one thing, Peter. We talk a little bit about adolescence because that's basically where insulin resistance comes to bear, and you start seeing kids with higher blood sugars and some even developing type 2 diabetes. But reality is we're seeing a lot of kids in the 2, 4, 6 age range where they're already off the map.
Wow.
Now, most of our audience who deal with pediatrics know this, but perhaps some of our adult folks don't. You have to plot them out on a growth chart because if you look at their BMI, it's by percentile.
Right.
So a BMI of 22 in an 8-year-old is going to be off the map.
Okay.
But it's alarming to us to see these trends so early.
One of the things I also want to do about pediatricians, if they do identify significant lipid problems, I mean, are most of them aware of the fact that it's okay to start statins at a certain age, and same with ezetimibe or PCSK9s? I mean, is that well known? What age does the FDA approve these things for?
Yeah, so they are approved in pediatric patients, I would say, and down to age 8, actually, and sometimes you have to use them even sooner, depending on the lipid levels. But I would say, as Don alluded to, our pediatrician friends are busy. They are busy people just doing well child checks and getting vaccines done and making sure, things are happening. And so that's what we're here for, so they might do the screening, but we don't really ask them to do actually the management or start medications. We often do a trial of lifestyle intervention, some diet stuff first. Sometimes, implement physical activity, see if we can get any improvement. And then if we're moving to medications, that's what we're here for, is to really try to help them out and guide treatment.
Yeah, so if they've got significant LDL elevation, probably FH or polygenic hypercholesterolemia might be better. Earlier is better in considering starting.
So I think Amy would agree with neither she or I could do the pediatrician's or the family physician's job, nor did we ask them to do our job.
Yeah.
Right.
So we partner with them because these are very complex decisions that we have to engage families and make sure that they understand what the repercussions are. But the other thing is that I don't know that the pediatricians necessarily have the time. Sometimes the family docs do because they're taking care of the family, but the entire family needs to be both screened and treated for any of these disorders, particularly the genetic disorders like FH. And so as a consequence of us diagnosing a child at 10 years of age, we've actually picked up a lot of parents because we urge them to go get screened. Yeah.
And then screen the rest of their siblings out to the side.
Yeah. And some of these folks have, turned out not to have, not necessarily to have symptoms, but they actually have coronary disease that they're not aware of. So, it's kind of a backdoor approach, but any way you get there is important as we improve the health of all the family.
Wow, that's amazing. So one question I have is, if you do get obesity, type 2 diabetes, sort of these cardiometabolic complications in adolescence, do you guys, as specialists, do you take on obesity management? Do you do GLP-1 receptor agonists and
Yeah, I do. But that's because I also see kids with type 2 diabetes. I actually just sat for my obesity medicine board. So to be determined if I'll be certified in obesity medicine. But yes, up until about, I would say 2019, treatments for type 2 diabetes in kids were very limited. We had metformin and insulin.
Right.
And that was it. But over the last 5 years, that landscape has completely changed, both for weight, so for elevated BMI. Some of the GLP-1 receptor agonists are now approved. And then for type 2 diabetes in kids, we have SGLT2 inhibitors and GLP-1 receptor agonists. But I would say, we still face challenges with getting approval of medications.
Yeah.
We still, and cost, out-of-pocket costs and stuff. So while I think we're doing a whole lot better than we were, we still face some challenges in the pediatric age range in getting these medications to all the kids that might need them.
And I know that the dual agonist, GLP-1 GIP, tirzepatide, is not approved in adolescents.
Although they just published the data.
They have.
In type 2 diabetes. And so maybe, hopefully, soon.
So it takes a while for these drugs that are first approved in adults, obviously, to matriculate backwards to children, but those will come. We're blessed, perhaps Amy is, I don't know, but, back to resources, we're actually blessed to have a clinical pharmacist work in our clinic. And so they're very helpful, not only in terms of informing us about side effects or potential problems or drug interactions, but also in terms of the pre-authorization that's necessary to get these drugs approved.
Oh, wow.
And particularly for the insurance companies, you don't want to make the mistakes of incorrect diagnosis or language up front because it really slows it down. But I think they're also very helpful in terms of being very user-friendly to the families and answering their questions and concerns so that they understand that we have that full array of knowledge and expertise to bring if they want it. One of the things that's very interesting, perhaps you know this, but in the adult world, a lot of the family physicians, internists see these type of patients either with metabolic syndrome or lipid disorders. That's entirely different in our practice. So I would say that very few, if any, pediatricians actually manage diabetes because of the complexity, and then same thing for lipid disorders. So and that model works well for us.
Okay.
And I think our pediatric colleagues, both family medicine and pediatricians, again, do a wonderful job. I couldn't do their job.
Yeah, well, that's
I will
amazing.
add one thing, though, because I think what's really different about pediatrics from adult medicine is now we have some more tools that we can use in terms of medication. But I would say probably the primary focus still is on prevention, if possible. When we start to see that BMI increasing up, want to prevent some of these things from happening. And then even taking a little bit more time to allow for lifestyle modification.
Right.
I think we really in our clinics work towards that. And even if we are using medication, don't forget that piece of it, because we're dealing with, young kids at times, or young teenagers, and this is potentially a lifelong
It is.
process for them. And we really want to develop those habits and develop them with the kids, with the teenagers, as they emerge into young adulthood, but also with families, because it really is the family support system that these kids need. And so the more the parents know, the more they can help support things
Yeah,
at home too.
that's so crucial, is parental support. But one other thing I wanted to get at about the metabolic syndrome is, and the use of GLP-1s, whether this helps not just weight, but if they have presence of MASLD or PCOS, does that help get you a GLP-1 a little bit?
No.
Not in pediatrics.
Not in pediatrics?
Not yet. Not yet.
Okay.
But I admire what the adults have done.
Yeah.
Type 2 diabetes
Yeah.
is pretty much the
But-
only one you can guarantee.
Only
And
one
even then, it's only a couple of them. It's not all of them.
Let me add to what Amy said very nicely, and that is, if you separate out lipid disorders, which for the most part are genetic, it's a little bit different conversation than metabolic syndrome. And the reason I say that is because the newer drugs that we have for metabolic syndrome for the first time actually work, and we feel reasonably good about them, but we don't know long-term side effects from these drugs. But not everybody can tolerate them, or they're not available to everyone. But the point being is that we all get excited about an intervention that's going to help these kids, but that's just now, that's right now in teenagers primarily, right? So the big job is we're actually moving that back to the true prevention, because as I said, we're seeing kids off the charts at 2 years of age. So we've almost lost the ball game from the beginning,
Yeah.
right? And so by the time these kids get to be 16 years of age, there's no coming back from that
Yeah.
without some kind of intervention.
Mm-hmm.
But point being is that we're all excited about new drugs and everything, but don't lose sight of the fact that the job is not over.
It's not. It starts early. One just quick, in adults, we always have the option, depending on the severity of obesity and comorbidities, of using bariatric surgery. Is that ever something that's considered in adolescents?
So we actually do that a lot at our center. So we have a large bariatric surgery program, and have since the early 2000s, actually. And so I think what we're recognizing now is, as you kind of alluded to, it's not just weight loss surgery, it's metabolic bariatric surgery, and it's associated with a lot of improvements in overall health. We used to also maybe think about it late in the game, so when you kind of had tried other things and nothing else was working, you would kind of go to surgery. And I think that mindset is kind of shifting a little bit, because as Dawn was kind of alluding to, sometimes at these young ages, we're already late in the game.
Yeah.
And how do you improve multiple comorbidities at a single time? Still not certainly for everybody, and it's personal choice, but that's part of the shared decision-making process. We talk about it with all of our patients as a potential option when we're talking about lifestyle interventions, medications, and the potential for metabolic bariatric
Well,
surgery.
it seemed to me that bariatric surgery, like in adults, it is a longer-term strategy. I mean, if you've got a high enough risk patient, you can try a lot of medicines if you want to manage all the complexities of their comorbidities. But if you get enough weight loss and maintain it with bariatric surgery, you get a better long-term outcome. So maybe in some situations, it might be a...
Well, I think that bariatric surgery has come to the point we feel comfortable recommending it even to children. Not that that's our necessarily go-to, but some of the kids already have hypertension. Girls have PCOS. They have a BMI of 45.
Oh, wow.
But as Amy said very nicely, we need to, in everything we do, really emphasize that lifestyle modification or healthy living is a part of that. And, I think that the strategies using bariatric surgery are kind of in flux now, because now we have drugs that are quite effective, but not everybody can tolerate those drugs. So what do you do in that situation?
Correct.
Right? What if the drugs are not affordable to kids?
Correct.
Or available to them? So I still think they have kind of complementary roles. The thing that we try to do, for example, with GLP-1s is say, we're going to use this to kickstart the effort with the idea of working you off of that. Okay, so if you can implement lifestyle changes, we want to see if you can sustain or maintain. And I suspect the answer is there will be some that can, and many may need a touch-up later on. Some may actually do that for a while and then require or benefit from bariatric surgery. So I think we don't have to be wed to one strategy fits all. We just need to see what the patient's needs are.
Do you think that adult medicine providers are ready to accept your patients when it comes time to pass them on? Are they?
Well,
How do we get them to understand what needs to be done, what you've done, and what the big picture is? How does that happen?
I think the better question is are our kids going to go to adult medicine? Because they don't want to go.
I know, and you don't want to leave them either.
We
do
don't
you?
want to leave them, and they don't want to go. And we do struggle with that. There's this period of kind of what we call transition, where they're kind of a little bit older for the pediatric space, right around that early 20s, and not the adult providers might not be ready to see them yet, but it's such an important time, especially for these kids that have childhood conditions. They really need to. So we've made really good efforts to try to partner with our adult colleagues that want to see them and see them early. Try to make sure they have appointments, and things like that. But it's something where it's kind of new if we think about it, right? Now these kids that we, started seeing in the early, 2000s and in, 2010 or so are now emerging into adulthood, right? So they're coming along with longer times for some of these conditions. So I think it's still to be determined, but we want to get them there, and we try, but it's, transition medicine is complicated.
And have the provider accept what that transition is all about, and having the pediatric patient to realize they're now an adult and that they need to be seeing adult doctors.
Yeah.
But I think the NLA is trying to increase this awareness about all of this so that the adult NLA members might be the ones who were willing to accept
That
these
would be
patients
great.
in the transition and be willing to carry that forward and understand how to do it. So that's what I'm hoping all of this educational aspect is about.
Well, just a thought on that. If you think about what happens if you have a child in your practice, and Amy's right, we're reluctant to give them up, and they're reluctant to leave, but that needs to happen. But when the kids get to be 18, you have young people that are going to college, some are joining the military, some are joining the workforce. The problem is transition care, where are they going to be?
Right.
Like you said to an 18-year-old, well, where are you going to be next year in college? And the kid says, as far away from home as I can be.
Yes, I can get, yeah.
And at the end of the day, okay, well, that was cute, but where are you going to be? And he doesn't know. So at the end of the day, it's not like calling your buddy across town and say, would you pick this kid up? So all that's to say is that one of the things that we work very hard on, I know Amy's group does a great job at this, is educating the kids between the ages around 16, 17, 18. What is your condition? What have we done in the past? Why is this important? What medications are you taking? What are you looking for? And then cultivate a climate where it says, we've had a mutual conversation, understanding, respect, hopefully. That's what you're looking for in a physician.
Right.
Go find them.
And
we can give you some
need to find them,
suggestions. Yeah, we can give you some suggestions if you stay in town.
That's right.
Yeah.
But if you're going out
You go out of town, may be able to give you some suggestions.
But
in a
if
few
they go
places.
to Texas, I can maybe find a friend.
But there are other places that the NLA has that you can search for people who might be interested in.
But the point being is
space.
that's what we want for all our kids and
Absolutely.
families is empower them. I guess what I'm saying.
I absolutely agree, and I think that's the key to lifelong prevention and improvement in cardiometabolic health is.
And we share with them, look, life's only going to get more complicated, right? You're going to get a job, perhaps a family. Hopefully you have some personal interests. You want to travel. I mean, don't lose sight of the fact that you need to stay healthy and
Take
live
care
a
of
healthy
yourself too.
Yeah,
Put yourself
exactly.
high enough on the priority list. That's awesome. Listen, guys, thank you so much for sitting down with me and going over all of this. I certainly hope all of the audience has gained a lot of insight on this, and wherever you are in your provisions of care for patients, you understand how this is so important in a young person's life and their journey to long-term cardiovascular disease prevention. So thank you all very much for tuning in.
Thank you for having us.
Thanks, Peter.